cual me siento muy honrada de presentar. Él es mexicano, es médico, psiquiatra y después realizó una especialidad en medicina del sueño, su especialidad. Tiene una amplia carrera y una amplia experiencia en esta área de medicina del sueño y es, como les decía, amigo de la sociedad, continuamente viene acá a trabajar con nosotros. Desafortunadamente, y sí lo voy a decir, él no trabaja aquí en México, él trabaja en Estados Unidos y trabaja en el Sleep Medical Associates of Texas en los Estados Unidos, y la plática que nos va a presentar hoy es Sleep and Psychiatry, y con ustedes el doctor León Rosenthal.
Hello, good morning. It is a pleasure to be with you today, thinking in terms on how to approach this subject and comply with the task assigned to me. I want to behave as a psychologist and not as a psychiatrist. We all have a bias, and even though I'm a psychiatrist, my research work has basically focused on sleep. So as you can all see, there is a very marked bias towards that area. First of all, I would like to share with you what this means to our medical field. And if you allow me to get a little bit into the philosophical part of sleep, I want to remind you that both in the Old and the New Testament, they allude to sleep as a small death. And there are many different writings on that regard. A rabbi wrote some comments about sleep many years ago, and they caught my eye because it is highly intuitive and very important for our life conceptualization to read this. If we were not to sleep, there would be no mornings. The life would be an eternal and unique today. Every thought and action would be a consequence of our previous facts or doings and consequences. So the concept itself of a new beginning would be foreign to us. That is extremely relevant because actually every morning, every awakening is a new beginning. From the physiological standpoint, we all know why it is important. I'm not here to convince you, but from the standpoint of life, this is like an anchor that allows us to focus on our comments today in terms of our sleeping. And let me share with you something that Gandhi said. Every night when I go to sleep, I die a little. And the following morning when I wake up, I feel like I have reborn. This is important because this was a man who knew about two status, the alertness one, and he also acknowledged the importance of sleep and could put in like a pause to everything that required from his attention throughout the day and then fall asleep. This is not what we see with anxious patients, with sleepless patients who are only acquainted with one single status, and that is a prolonged and unique anxiety status. Many of the things that they feel are tolerable or are adaptable to somebody else are really like a poison for them that do not allow them to sleep at night. And it is along those lines that society, that civilization has been interested in our discipline in sleep medicine and has tried to understand not only what happens from the standpoint of sleep awake but from the standpoint of psychiatric morbidity. And it is along those lines that in the 1980s, the first census was carried out. We had mania, melancholy, monomania, paresis, dementia, dipsomania, and dementia. And I want to call your attention to the fact that sleep is not mentioned, is not interesting for any medical aspect. By the end of the 1800s and beginning of the 1900s. And then we jump to the year 2013. DMS-5, as you all know, was published several years ago. It is made up of 22 diagnostic categories, among which we have sleep disorders. How is it that from 1980 we went all the way to 2013 before understanding that in the particular case of insomnia we have different categories and we have insomnia among those categories. In this story we have the whole sleep medicine development intertwined, and that truly starts with neurophysiological aspects. They told us about Dr. Berger's work yesterday. ECG, then some trials made in humans. In these 30 years they used to think that sleep was like in an inherent moment. It was just the same to record 1 or 8 hours. Everything seemed to be the same, and there was no true acknowledgement to physiological relevance of sleep. Then exploration of sleep started in a very, or study of it started in a very systematic way. There was the description, this was published by Natalie Cloudman, the first sleep or night record, and this is another historical piece of information. The slide is quite dark, but this is Bill Dement and Christian Guilleminot and Dr. Murcia at Stanford Laboratory in the first years of the sleep lab work. In 1982, the first classification of sleep disorders was published, and it has now received the name of International Classification in its most recent classification, that is 2005. The new one is just about to be published in a few weeks. So we can see how psychiatry and sleep are being intertwined. We have recognized sleep, we have recognized certain patterns, and this defines insomnia. At a consensus conference in 1986 in the Health Institutes, insomnia was defined as a symptom and not as a primary clinical entity. Us veterans were educated, were taught like that. Then a change came about, partially because of the data I'm going to show to you, where insomnia is acknowledged as a pathology per se, and it is typically recognized that there are some very important comorbidities. So we have migrated from what we used to call insomnia due to depression or complications or psychiatric disorders to the fact that there is insomnia and some associated comorbidities. This is what the American Association of Psychiatry states with regards to sleep disorders, and they emphasize that there are coexisting conditions. On the next slide, I want to show you what from the diagnostic standpoint would involve that primary insomnia symptom is left aside and insomnia is acknowledged as an independent entity, whether there is depression, schizophrenia, bipolar disorder or not. If the patient complies with all insomnia criteria, then any psychiatric diagnostics will be given in addition to the insomnia diagnosis. So this results in a dramatic change, at least from the standpoint of those of us working in the sleep medicine area. This results in higher potential of patients with potential complications because, you know, society as a whole and us in particular need to take the leadership in management of this problem. But I want to show you how the diagnosis was made operational in DMS-5. So how difficult it is to preserve sleep, which are the problems in sleeping early. There is enough distress recognized by the patient. We have talked about consequences and we will discuss them throughout my talk. And something that I will repeat time and time again is that we're dealing here with a chronic condition. It needs to occur or to be present 3 times a week for a 3-month period. Whatever you don't see shown on this diagnostic criteria, what you will not see here is that there is no polysomnographic diagnosis in our bias. We have information, relevant information missing about what really contributes to a better sleep quality. Some breakthroughs have been made, but not enough. And here I tell you why polysomnography hasn't decided to include this. And among some other things, I want to tell you that this individual sleeps around 90 minutes a day, a little bit of apnea, but based upon any objective criterion, the would have slept well. Nevertheless, he or she says that there was a poor quality of sleep. This is what we recorded from our standpoint and what we recorded from the patient's perspective. Then this is a patient who recorded 66 hours and a half. This is the N1 stage, which is quite exaggerated, some apnea, and nevertheless she says that she slept well. So even though we can try to figure out what really happened and maybe build a whole castle in our minds, we are not using purely clinical data. Polysomnography, I think, has a role to play in the treatment of sleepless patients. Maybe the APA or the Sleep Society need to launch an indication for insomnia. And even so, we wouldn't be doing enough. And why is this so relevant? Because chronic insomnia is prevalent. I'm sure that up to 10% of the population have insomnia, or maybe even up to 30% of the population have insomnia at some point in their lives. Age is a risk factor. As you all know, there are changes in sleep physiology. These are the changes that could lead us to other changes, and when we age, we have more medical conditions, and if the person has a variety of medical conditions, insomnia prevalence will be higher. So as we age, insomnia goes up, we have more medical conditions, and there might be insomnia prevalence of up to 40% in adult populations who are older than 60 years of age. And I would like to spend a little bit more time talking not so much about family history. There is not enough information on genetic factors, but Dr. Prosper and myself talked about how important this challenge is. Maybe in some years we could listen to your vulnerability talk. But what do we know about vulnerability today? This is an essential study by Dr. Ford's group. We had homozygous and heterozygous twins, and the first scale was used. This is a subjective rating scale assessing predisposition of the individual to having insomnia. This is a subjective reference of having sleep disorders, and once again they use this subjective scale, and through statistical methods they try to assess what the genetic contribution is using this twins pool. In men, the genetic factor was more important for first scales, and once they controlled through other factors, the correlationship was similar. This is a very reasonable correlationship, I think, from the statistical standpoint, and several trials have been carried out with this instrument. Those with high ratings sleep less, have more important latencies based upon the polysomnographic registry, and they have some higher latency test levels. So we can see that there is some vulnerability from the genetic standpoint. There is a genetic and an environmental factor. Obviously, the percentage in each of our patients would be hard to determine. We have plenty of studies having been carried out in the last few years, but the last set of studies presented at Dr. Prospero's samples show how these patients were followed for 7 years. They used the Moose scale, parents of children of 7, 9, 13, and 15 years of age, and the scale showing family conflict is here. Those without a family conflict had low incidence of insomnia at 18 years of age, and those with family conflicts and who repeatedly expressed that through a number of years had a very high insomnia incidence. So both genetic and environmental aspects play a role in insomnia incidence. Another very interesting concept, and this comes from Penn's group, is that person who does not identify him or herself as sleepless, but thinks of him or her as sleeping very badly or having a very poor sleep quality. These individuals were followed for 7.5 years, followed up, and they said, yes, I have insomnia. I have had insomnia for more than 1 year. I don't sleep well at all. And there were also people who reported having sleep disorders. Then they were assessed with this questionnaire, and on the next slide I show this very complicated slide. I didn't have time enough to rearrange it, but these are the ones who were considered to be normal and then evolved to having insomnia, and these are the ones who had a poor sleep experience and that were later identified as having insomnia. I'm not going to disappoint you. This is a terrible slide, a lousy slide, but these were people who were followed up at the very beginning. These are the ones who were not sleeping well, but that during follow-up reported insomnia. From all the variables expressed here, these were the people with more health conditions. This was more prevalent in this group than in this other. And these people were basically women, and they were heavy smokers. So there is somewhat different predisposition. Nevertheless, there are people, that's what I want to tell you, there are people who always say, I don't sleep well, but do not necessarily identify themselves as having insomnia. When they get to the clinic and they report having insomnia, they said, well, I didn't used to sleep well, but I didn't have insomnia in the past. These are data from the last 2 years, very important in terms of bidirectionality of insomnia and psychiatric disease. And what we all know about comorbidity, depression, and insomnia. The first report was carried out in 1989 when Ford and Camero reported that insomnia was identified as a significant predictor of subsequent major depression. Actually, this was not appreciated enough or welcome enough. In 1989, when I worked with Ford, we carried out an epidemiological study, and we didn't only find that this was a risk factor for depression, but also for anxiety and for drug abuse. And here, let me tell you that 30 years went by before we were able to change our minds, before incorporating these factors and these findings among diagnostic criteria. What we are seeing in the new nosology is the result of these studies, the impact that research has had, how important, how relevant research is, and how it is capable of modifying our criteria. Had it not been for all the research made, we would still be anchored on our old concepts. This is an extremely interesting fact. Chronobiological disorder with sleep onset insomnia, its relationship. Elliot Weitzman, one of the insomnia pioneers, identified that chronobiological disorders were part of the risk of having insomnia. This is something that has not yet been studied in depth, even though there are multiple theories. You know that the old literature shows theoretical models accounting for depression based upon, or explaining depression based upon chronobiological disorders, early awakenings, short latency times, among others. And the study that I want to show you, and that is somehow different, illustrates the huge field still to be discovered that we have ahead of us. Schizophrenic patients were recorded for 6 weeks in an actigraphic way. Then they were compared to a group of subjects who were comparable. These were patients with schizophrenia, chronic patients who were medicated, who were stable, most of them unemployed, and they were compared to a truly comparable group who were also unemployed. And findings are truly amazing. Variability in sleep latency and awakening at the end of the sleep and the sleep midpoint during the sleep period was entirely different for the schizophrenia group and the control group. So half of the patients with schizophrenia had a circadian problem or such drowsiness that were in bed for long periods. This is the extremely high variability. When melatonin assessment was made, they identified that there were key changes. There was this delayed stage. They identified people who didn't have a 24-hour rhythm. So it's truly impressive to realize how we missed this in the past. This is in the case of schizophrenia. And in addition to these risk factors, we also need to acknowledge that there are several consequences from insomnia, and they range from medical to social and contribute to the complexity of the problem. Something that could seem hard to believe is that insomnia patients with sleep latencies of more than 30 minutes have greater mortality risk as compared to controls, and the same could be said when comparing data that reflect sleep efficiency. In the case of high blood pressure, this is another very busy slide, but I just want to focus on model number 3, where they assess insomnia as a hypertension risk factor. They try to control all the possible variables you can imagine. 3 key factors here. Insomnia is a risk factor for hypertension, especially if they are polysomnographically recorded, and those who sleep less than 5 hours have an even higher hypertension risk factor. And obviously when people don't sleep, there are more absences at work. I mean, they don't go to work, and they have very serious sleep disorders as well. I want to stress this out. People might get to work, but that is called presentism. I mean, they are at work, but they are not producing anything. So they report sleep disorders, specifically insomnia. Let me tell you that there are less slides now than when we started. Don't get bored. This is a concept that we have studied for many years. Top 15 causes of lost work time, absence, and presentism. From the standpoint of my research interests, this is something that we have studied at length. These are data that really increase that idea that insomnia patient has this status of hypervigilance, hyper-alertness, and we've always known from the MSLT in insomnia and control subjects, as well as from subjective insomnia tests, that there is a high percentage of people who are not hypervigilant and who have daytime drowsiness. This is from the Henry Ford group of work. They compared people without medical conditions, and they were compared to insomnia patients, and we can see that as a group they have a hyper-alertness status. This is latency of more than 15 minutes. But there is another group of patients or subjects who are clearly sleepy during the day. And the question is there any predictive factor in the way they sleep? And yes, that is the case, because you know that people who are more sleepy sleep much better than those who are hyper alert throughout the day. And this confirms what we have said, that sleepless patients, or that truly insomnia patients, are hyper alert both during the day and during the night. Here I summarize plenty of data. I want to convey some key ideas, but the hyper alertness status is reflected at different levels. From the multiple Knopfsinger works, we can see that hypermetabolism in insomnia patients is totally different. Insomnia patients have a faster metabolism both in the waking hours and during their sleep. Some other Knopfsinger data, the arousal systems in insomnia subjects continue to be awake. They do not deactivate efficiently from waking to sleep. These are Ryman data. He assessed the hippocampus, good sleepers, insomnia patients on the other side, and he used the previous primary insomnia rating. There are anatomical effects also in these patients. They have effects on catecholamines and on temperature rhythms. This is all that we know about the different consequences studied in insomnia patients. So we have a large amount of information point to the fact that these patients have a systematic behavior in the different measurement dimensions. And Ryman, in another publication several years ago, summarized this very effectively. Insomnia may be conceptualized as the final common pathway of the interaction of a genetic vulnerability to an imbalance between arousing and sleep-inducing brain centers. This is sudden disequilibrium due to maladaptive behaviors, learned sleep-preventing associations, and cognitive factors. So something that is quite interesting and challenging from the medical standpoint is precisely that. Those perpetuating mechanisms, when maladaptations of patients or having had learned poor sleeping habits and all of the cognitive factors trigger those psychosocial or medical stressors and are activated and perpetuated, the more insomnia endures in time. Summarizing, what I have wanted to convey to you is the following. Insomnia is a chronic condition. From the standpoint of diagnosis, that should take 3 months, but at least for those of us in the clinic, we know that it is a chronic condition. When we assess the patient, we have to understand where he's coming from, what has happened throughout his or her life, where is the patient today, and where will the patient be a few years from now, or where will it be in the future, so that we can better management him or her. This is something that we have been working in the last few years. I have been working hand in hand with an anthropologist from the Texas University. We have assessed insomnia patients at home, at their homes. And we've learned something really interesting. This has taken us beyond our clinical limits. We have been able to see what the patient is living at home, and not only what he or she is living at home, but what he or she is doing at home. So if we assess a patient 10, 15 minutes, or ideally an hour, that is a very small window about what the patient is doing at home. And these studies carried out with my anthropologist colleague have opened my eyes widely, because we see that we have made several mistakes and omissions when assessing the quality of sleep and assessing insomnia. We have to be very careful with our treatment of behavior and with conceptual treatment of insomnia. And in just two concepts, I want to summarize what we've learned about insomnia in the last few years. This is regardless of comorbidities, regardless of good or bad quality of sleep. There are two important types of insomnia patients: the adult who is active, who is working, and who has insomnia problems. Hypervigilance that might lead them to feel unrest because they cannot go to sleep, and they say, oh, how will I be able to work tomorrow? This is has perpetuated in anthropological studies. The other aspect is the elderly patient who changes because he has all the time of his life or her life, and he wants to sleep as much as he wants to and whenever he wants to. But you know, sleep is not on demand, and is not something that can take place whenever we want. My previous colleague has already talked to us about what happens in adolescent years, but in adulthood, circadian rhythms are not as systematic, and the problem of staying in bed for too long can be worsened. I say this because on my last slide I show that this has implications for sleep quality. I have been working at the sleep clinic, managing patients for more than 25 years. And the time frame has changed in terms of these patients' management. I used to think that I had to put them to sleep no matter what, that I would have to use any pharmacological intervention, polypharmacy, to put the patient to sleep. But now, after being in Dallas for more than 13 years and working with a group of chronic insomnia patients, my perception has changed. We have to make a team in the long term, and if the treatment is focused on taking a pill and believing that that will solve the problem, that will be useless for those patients. And the really hard work is to get them involved in behavioral changes. That is, I know, much easier done than said. But this is the Vicey slide showing that they followed patients for more than 10 years. The message is consistent with what I said before. 60 or 70% of patients with initial insomnia still have insomnia 10 years later. So this is not only what I have told you in terms of my clinical experience, but about some others' experience. And the question for 2013, just a few months after DSM-5 has been launched, and you know that it has been highly controversial. People from the National Institutes of Health, psychiatrists, really showed how strong they felt, how negatively they felt about introduction of the new DSM-5. But changes are very favorable for us sleep experts. Very favorable, but very complex. And that's where the true danger lies. And I stress this out, medication is not the cure necessarily. Based upon these criteria, any patient with any type of problem, whether medical or psychiatric, if there is insomnia in his life, he has to be administered a hypnotic. And that's one of the strongest criticism to DSM-5, that it is going to do away with a very, very serious polypharmacy problem. That DSM-5 bias is very much in favor of the pharmaceutical industry. So the subject of this presentation is very pertinent. Where are we standing today? Where are we heading towards tomorrow? Even though there will be people telling you that there are wonderful medications and that we are just about to witness the launch of a new medication by Merck, a new hypnotic agent, there will be plenty of people telling us how to treat insomnia patient. But insomnia patient is a complex patient, and the drug is not the only cure mechanism. Thank you very much. Thank you, Doctor, very much. A very nice talk. And now we open the floor to questions and answers. Congratulations, Dr. Rosenthal. Do you believe that some patients that have been labeled as with schizophrenia might have an underlying problem of insomnia, and maybe they are asleep in their waking hours and that is taken as schizophrenia? Well, I'm sure that you've read the literature and you might remember that there was this time when patients with schizophrenia were reported as having been misdiagnosed with narcolepsy, for instance. I don't think that exists, that truly exists. And I mean, I don't think there is a schizophrenia patient that has been diagnosed as having, a patient that has been diagnosed as schizophrenic who is only narcoleptic. There are patients with schizophrenia and narcolepsy, but there are very few. On the other hand, I showed the slide on circadian rhythms and sleep habits because I feel that we don't understand what the chronobiological aspect is or how it works specifically in people with insomnia. I didn't suspect about those data. I was really shocked, and there is still a lot of work to do in that area. I don't think that it is a sleep problem per se. It is a chronobiological problem. Well, I don't really know yet, but maybe chronobiology could help us answer the question. And management of schizophrenia and narcoleptic patients is extremely hard. We have to acknowledge that. Congratulations once again for a wonderful presentation. I would like to ask a question regarding the effect insomnia has on arousal. That is, there are some hints about what happens in problems similar to neuralgia, but let's say with behavioral therapy or pharmaceutical therapy, could we help solve that problem? Hyperarousal. Yes, there are data in that regard. Tom Rods has shown data with temperature rhythms using zolpidem in the long term, and also there was a report, I believe, with catecholamines. So there are not as many reports as we would like to see. There are isolated reports. Well, many times at my clinic with my patients, I try to tell them that taking drugs, taking medication is fine, but that they also need to go to behavioral therapy. What do you tell your patients about those trials who have shown that association between taking medication for long periods and cognitive loss and higher mortality rates? Well, that is very controversial, you know, because on the other hand, there are data that don't point out to such prolonged years, but there is 1 year follow-up showing that there are no major problems. What I tell my patients is the following. What I tell them right now, and I've told them this for several years, you have to set the rules of the game from the very beginning. You have to tell them, this is an issue, this is a condition that we will not solve. The likelihood, chances of solving, the likelihood of solving this is very, very low. We have to have a rational expectation. And on the other hand, I tell the patient that we will have to work together. I do not impose behavioral therapy upon them. Maybe they cannot pay for that, maybe they don't have insurance for that. But as we see them in time, I involve several cognitive or behavioral aspects that I consider to be important. Since I know that I will be seeing them for many years, first of all, I want to be sure that I'm not administering, that I'm not prescribing too many medications, that there are no some other aspects that I have missed. When you were asking your question, I remembered, and that is something that Tolto and all the chemists take a look at. Several years ago, and especially here in Mexico, there will be a boom of people saying that they can make you sleep. And there will be people, peddlers on the street selling sleep equipment, sleep instruments. There is a physician within the Dallas community, and he carried out a primary study on a patient and showed that he had apnea, moderate apnea, hypopnea of 20. That was a rate. Sorry that I didn't bring the case because it's very illustrative. CPAP, he did not tolerate it. He started zolpidem on him. The patient started taking zolpidem, and he took zolpidem to such a degree that the physician said, hey, you have to stop it. He tried to stop him, and he started having panic attacks. So the patient was referred to the clinic. right away. He was assessed. And it is interesting to see how patients know how to identify themselves. He didn't talk about snoring. He didn't want to talk about the fact that his wife was worried that he stopped breathing. In that lapse, the patient gained around 25 kilos. So could you imagine what was happening with the apnea-hypopnea rate? We did a half night. He had an index of saturations. He was taking zolpidem every day, and CPAP was started on him. CPAP, he did fine with CPAP, and well, he could lower the dose of zolpidem because he didn't have to be knocked out to go to sleep. So the critical aspect is also what we have in writing and many things that we've discovered in time. It is nevertheless very important to have the background, to be certain about that what we're doing is correct, because there will always be people that will anchor on that medication, and we might have to refer them to psychiatrists or to addiction experts. That is not an isolated problem. León, thank you very much for your presentation. I would like to ask, well, hyperarousal is considered as one of the cornerstones in the insomnia nature. Could you tell us what part of the hyperactivation would be the result of our incorrect use or misuse or abuse of hypnotics in terms of side effects? Well, I haven't thought about it, but we would have to do some research. We can do that. That's a very interesting question. Yes, because many insomnia patients take 1 or 2 pills of different products every night. They have some tolerance, they have developed tolerance and withdrawal symptoms. So why dismiss the possibility that that is also part of hyperarousal headache that is frequently reported as side effect? That's an empirical question that is worth considering. And the aspect that I would like to comment with you that is not as important as what I wanted to convey to you is, I don't know if you remember the LMST slide from Wars and 4. There are insomnia groups of patients who are drowsy, who are sleepy, and with DMS-5 classification, we're not improving in our understanding of that people. So DMS-5 is a good effort. It incorporates things that are important to us. It acknowledges the importance, the relevance of sleep medicine, but under no reason can we believe that that is the panacea. We don't have any targeted study assessing sleep disorder. We have very important gaps between what the patient perceives and what the patient shows. So we're just at the threshold. We know very much, but we still know very little. Moving along the same lines, my question is if he wonders whether hyperarousal is part of insomnia patients. What does that have to do with homeostasis? Roth's study about drowsiness or sleepiness would just say that those with drowsiness do not have an alteration in their homeostatic mechanism, and those with high latencies of sleep with multiple latency tests have
an alteration in their homeostatic process, or how would you approach that? That is very complex. On the one hand, I said that those who were sleepy slept better. So regardless of their homeostasis, it is preserved. And the other one, because I didn't want to take too much time in that, we did some studies in the 80s. We assessed homeostasis in insomnia patients, and it was not pathological. So the patient was sleep deprived and he was compared to the controls. The problem is that that has not been reproduced yet. And we also need to incorporate chronobiology. We need to understand that. We need to better characterize that and to better understand what Mary Cascaron commented about. What is the number of hours of sleep I need? Because an insomnia patient many times, well, sometimes we clinically suspect that their sleep need is relatively lower to the one he wants to have. I mean, the patient wants to be in bed for 8 hours when maybe they don't need more than 6. And the behavioral therapy studies show that the fastest and most effective effect, and we have also published in that regard, the most important effect is seen with those who restrict the amount of time they spend at bed. So don't you think that orexins would have something to do with this, and that new drugs working on orexins antagonism could also help? Well, the studies are highly promising. I thought about showing some slides in that regard, but I didn't want to convey anything pharmacological in my message. Nevertheless, I feel it is interesting and that it might open different doors to us in that area. The other day, and I was telling with some of you about it, whenever we listen to the new researchers in 10 years from now talking about their experiences with this medication, what will we be talking about then, 10 years from now? Will this be a medication similar to melatonin agonist that has done nothing, or will this drug substitute all benzodiazepines and non-benzodiazepines? What will we be talking about 10 years from now? Which are the things that had not been detected in preclinical trials? But you know, data are very good and the drug is highly promising. Thank you very much.